Okay, so basically we are going for the point number 21, which is flap. So here we are on the third part and the final part of periodontic synopsis. Then we are going to start the MCQs. So here it's the flaps. So in the flaps, the flaps can be classified in the full thickness or the partial thickness. So I will be writing here flaps, full thickness, partial thickness. Okay, so necessary full thickness, which are the mucoperiosteal, which is mucoperiosteal, and here it's mucosal. Both layers will come, and in partial thickness only mucosal flap. So obviously periosteum we are removing, then it's necessary in osseous surgery only, and as the bone is stripped, if it's of its periosteum, marginal bone loss occurs, and the bone loss is greater if the bone is thin, contraindicated when fenestrations and adhesions are suspected. Mainly used in osseous surgeries, bone is involved, and marginal bone loss occurs. If the thin bone is exposed, more bone loss occurs, and this is contraindication in adhesions and fenestrations. Contraindicated, right? Now the periosteum is left on the bone. In mucosal, the partium, only mucosal layer is removed, so the periosteum is left on the bone, and it is indicated when the crestal bone is thin and when fenestration adhesions are present. Obviously, if the contraindications are there of the full thickness flap, we will do the partial thickness flap, and it is indicated in crestal bones, thin bones, where the bone loss is far more than the other bones, and when full thickness flaps are removed. So full thickness flap, mucoperiosteal flap, and in osseous surgeries where the bones are thick, contraindicated in dehiscence and fenestration. In dehiscence and fenestration, we usually use the partial thickness flap, which are the mucosal flaps, and mostly used in crestal bone, where mostly indicated when there is a involvement of crestal bone. Okay, now these were the types of on the basis of the thickness. Now it's on the basis of the displacement. It's undisplaced and displaced. Okay, undisplaced, it's located in the position it had before surgery. Okay, obviously I have removed it from somewhere. I will attach it again onto the same place, then that is known as undisplaced. I have not changed its location and not displaced it, and it's known as undisplaced, and it is placed again to the place where it was before the surgery. It is also called internal bevel gingivectomy. Internal bevel gingivectomy. Okay, so it's also known as gingivectomy, internal bevel gingivectomy. Undisplaced flap and gingivectomy are the two techniques that surgically remove the pocket wall. Okay, undisplaced flap and gingivectomy are the two techniques that remove the pocket wall. What is displaced? It is made possible by totally separating the attached gingiva from the underlying bone. The underlying bone totally separated, we totally separate attached gingiva, and flaps can be displaced apically, coronally, or laterally to its original position. Like uska flaps position is something like that. Attached gingiva is removed. Now it can be laterally or more apically, more coronally, or it's apically, anywhere from its original position it is displaced. Then it is known as displaced flap. And apically displaced flaps preserve the outer portion of the pocket wall and transform it into attached gingiva. So it is eliminate the pocket and also increases the width of attached gingiva. So when we apically displace the flap, the pocket is outer portion of pocket wall is preserved. It is transformed into attached gingiva, and so it eliminates the pocket. The pocket is removed. There is no pocket now, but the width of attached gingiva is increased. So it's a good thing, right? Now, this was about the flaps, which is the full thickness and partial thickness. Flaps undisplaced and displaced, undisplaced are known as internal bevel giant sectomy, which is used for surgically remove the pocket wall. Displaced are apically, laterally, coronally. Apically, one its outer portion, it preserves the outer portion of the pocket wall. It's transformed into the attached gingiva, which eliminates the pocket, but increases the width of the attached gingiva. Now, we will see the majority of the oral where majority of microorganisms are facultative and aerobes. We know that majority of microorganisms are facultative and aerobes. Now, organism that predominates in early plaque are gram-positive facultative foci and rods. Okay, तो early plaque में gram positive होता है, which is Streptococcus sanguis and Actinomyces viscosus. Streptococcus sanguis and Actinomyces viscosus, which are the predominates in early plaque and are gram-positive facultative cocci. Organism that predominates in late plaque are gram-negative anaerobes and anaerobic rods and filament. Organisms that predominates in late plaque are gram-negative. Early plaque gram-positive, late plaque gram-negative. They are the facultative cocci and rods, and these are anaerobic rods and filaments. Okay, so gram-positive are the Streptococcus sanguis and Actinomyces viscosus, while the gram-negative are Gingivalis, Intermedia, Fusobacterium, Capnocytophaga. Bacteria associated with periodontal health are sanguis, mites, viscous, Capnocytopha, Neisseria, Veillonella. Okay, bacteria associated with periodontal diseases are Gingivalis, Intermedia, Actinomycetum comitans, Acanella, Fusobacterium, Eubacterium. These are disease related, these are the health related. Organism responsible for pregnancy, gingivitis, Prevotella, Intermedia, bacterioids, melangionechiae. When these type of questions are really important. So in gingivitis, pregnancy related, it's Prevotella intermedia. Prevotella intermedia, or known as bacteroids melaninogenicus. Prevotella intermedia, bacterio melaninogenicus. Facultative and aerobes microorganisms associated with localized juvenile periodontitis is Actinomycetum comitans. We all know that microorganism responsible for rapid progressive periodontitis is Actinomycetum comitans, Porphyromonas, and Gingivalis. Okay, Gingivalis, Actinomycetum comitans, and Porphyromonas are associated with rapid progressive periodontitis. Organism that initiate smooth surface caries are Streptococcus mutans. We all know this, it's very common. Smooth surface caries, Streptococcus mutans. Organism that causes progression of smooth surface. The organism which carries the smooth surface caries, it's Streptococcus mutans. Okay, organism that causes progression, it's Lactobacillus. Okay, responsible for root surface caries. It was about smooth surface caries, now root surface caries. It's about A. viscosus. Okay, commonly absent in gingival sulcus, diphtherioids. Diphtherioids are commonly absent. Organism acytotic concomitant is a facultative anaerobes. Gram-negative bacteria mainly they are responsible for periodontal disease and in juvenile periodontitis and rapid progressive periodontitis. We all know that 1 gram of plaque contains 10 raised to 11 bacteria. Remember, questions may be asked. 1 gram of plaque contains 10 raised to 11 bacteria. Now, organism that forms the longest chain. We are talking about salivarius, Streptococcus salivarius. It is the organism that forms the longest chain. First organism to invade the oral cavity. Most commonly present organism in saliva. Organism of Streptococcus viridans, group to cause, and Seabe after Streptococcus sanguis. Got it? We are talking about salivarius. It is the organism that forms the longest chain, first one to invade the oral cavity, most commonly seen in saliva, and group to cause organism Streptococcus viridans, group to cause, and Sabe after the Streptococcus sanguis. Organism which does not obey Koch postulate is the Mycobacterium leprae. It does not obey the Koch postulate. I will attach the Koch postulates image over the corner. Organism associated with enag are fusiform bacilli, spirochete. The spirochetes are mostly of intermediate size. Okay, enag is caused by fusiform bacilli, spirochetes. Spirochetes are mostly of intermediate size. Okay, got it? Fusiform bacilli, spirochetes. Fusiform bacilli, spirochetes. Co-aggregation is mainly seen in gram-negative organisms. So co-aggregation, gram-negative organisms. Quick revision. We have seen about the facultative anaerobes, cocci and gram-positive are Streptococcus sanguis and Actinomyces viscosus. Gram-negative are Gingivalis intermedia, Fusobacterium capnocytiva. Health and disease we have seen, and pregnancy, Gingiva prevotella intermedia. Actinomycetin comitants are for localized JP. Actinomycetin comitants along with porphyrimas and Gingivalis is rapid progressive periodontitis. Smooth surface caries is initiated by Streptococcus mutant, progressed by Lactobacillus, and root surface caries are initiated by A. viscosus. There is an absence of diphtheriates in gingival sulcus, and the A. actinomyceto committance is a facultative anaerobe, and 1 gram of flour contains 10^11 bacteria. And we have talked about salivaris. Mycobacterium leprae does not obey the Koch postulate, and fusiform bacilli and spirochetes are responsible for enag, and co-aggregation mainly seen in gram-negative organism. It was a quick revision. Now let's go to the last point, which is a quite big point, which has so many numbers. So we will just try to remember and just go fast so that we really need to, these numerical values should be revised again and again. Okay, so this is the basic, and if you don't have the pulse book, or if you don't have the synopsis, I will make a PDF and upload on the Google Drive. If you want, then please comment below. I can just make the notes of it. I am going to prepare a personal individual notes as well after completing whole perio, and from the MCQ part and from the synopsis and from everywhere, we will be making a good amount of handwritten notes so that we can do the quick revision of the perio at the end of the exam. But till now, as we have only few months left, we will just be doing quick revision, and after that, if we achieve our score, then okay. Otherwise, for 2026, we are going to make handwritten notes of each and every chapter, each and every subject, and including the CS. So come along with me and don't worry about your results. Just do hard work as I am doing. I am giving the first attempt here, and in first attempt I try to complete. I'm starting it today. As you all know, it's the 31st Jan, and I'm starting it today. I will be completing the pulse. I will try to complete the pulse. It may be I may be having 1 or 2 months only, so I will be completing the whole pulse, and I will try to complete the CS as well. But the main target is my pulse and give the exam so that I can understand what type of questions are asked. And if I get the admission, then it's a little, Sone pe suhaga. But if I don't get, I will not take it on my mind. I will be restarting it immediately and complete the perfect course perfectly, and sure I will get admission in 2026. Okay, now thickness of, see, these are the basic. We have really studied this number of figures again and again in our dentistry UG. So let's just do it quick revision. Thickness of junctional epithelium near the base is 10 to 12 and 20 cell thick. Length of junctional epithelium 0.25 to 1.35 mm. Histologic depth of gingival sulcus 1.8 mm. Probing depth of the normal gingival sulcus is 2 to 3 mm. Sulcus depth in primary dentition is 2.1. And thickness of periodontal ligament 0.15 to 0.38. Amount of GCF secreted per day is 0.5 to 2.4 ml. Oxygen coefficient of normal gingiva 1.6 to 0.37. Maxillary incisor region, the attached gingiva is 3.5 to 4. Incisor, mandibular incisor is 3.3 to 3.9. Maxillary first premolar 1.9. Maxillary mandibular first premolar is 1.8. Edge to edge contact of cementum and enamel occurs in 30% cases. The cementum does not overlap in enamel in 10% cases. Concentration of tetracycline in GCF is 2 to 10 times higher than that of plasma. Specific gravity of saliva is 1.003. I think this is important. Width of cementum is 20 to 50 micrometer. Width of cellular cementum is 150 to 200 micrometer. Gingivitis at peak level in which age? It's 12 to 15 years. Percentage affected by gingivitis by the time they cross their puberty, 80 to 90%. Population taking dilantin affect hyperplasia 50 to 60%, taking nifedipine affected by hyperplasia 20%, percentage of pregnant women who develop pregnancy gingivitis 30 to 40%, pregnancy of turning into pregnancy tumor is only 2%, pregnant plaque content 10 to 11 bacteria per gram. Minimum level of cyclosporine in plasma above which gingival hyperplasia occurs is 150 nanograms. Average daily increment in calculus form is 0.1 to 0.15%. Percentage of plaque that get mineralized within 2 days is 50%. 50% of the plaque get mineralized within 2 days. In 12 days, 60 to 90% they get mineralized. Effective radius of action of bacteria in periodontal disease to cause alveolar bone resorption is 1.5 to 2.5%. Duration of each masticatory cycle is 0.6 to 1 second. Number of swallows per day is an individual is 600 times we can swallow in a day. Right, nice. Swallow this 0.6. Total occlusal points in dentition is 138. This is also a good point. Normal calcium and phosphate precipitate concentration is 35 to 40. Dentine is abraded 25 times. More that of enamel. Cementum is abraded 35 times than enamel. Dentine 25. Cementum 35. Recommended probing force is 0.75 Newton. The diameter of standard probe tip is 0.35 to 0.55 mm. Distance between the base of sulcus and alveolar crest is 2 mm. Total number of the film required for full smooth mouth survey excluding third molar is 18 and 14 IOPs and 4 bite wings. Okay, this is good point. Full mouth survey, we have to do the full mouth surveys excluding the third molars. We need 18 IOPs, 18 films. 14 are IOPs and 4 are bite wings. Effective concentration of chlorhexidine is 0.2%. Minimum concentration is 0.12%. Diameter of bristle soft 0.2. Medium the bristle means the brush is soft is 0.2 mm, medium is 0.3 and hard is 0.4. Epithelialization after curettage occurs in 2 to 7 days. Complete reepithelialization after gingivectomy occurs in 1 month. Complete repair of connective tissue after gingivectomy occurs 5 to 7 weeks. After periodontal sulcus can be safely probed after 3 months. Maximum clavicular fluid production coinciding with the maximum inflammation occurs 7 days after gingivectomy. Ideal thickness of graft should be 1 to 1.5 mm. Functional integration of graft occurs after 2 to 5 weeks, that is 1 month. Ca by P ratio in hydroxyapatite alloplastic material is 1.67. Ca by P ratio in tricalcium phosphate is 1.5. This is 1.5 alloplastic, 1.67, tricalcium phosphate 1.5. The disparity between the centric relation and centric occlusion is 0 to 0.5. Junctional epithelium loses its cohesiveness and detaches from the tooth surface when the volume of the PMNS reaches. Frequency of ultrasonic vibration 20,000 to 45,000. Frequency of electric currents used in electrosurgery 1.5 to 7.5 million. Width of marginal gingiva is 1 mm. Main keratin component of stratum corneum is K1. Thickness of basal lamina 300 to 400. Thickness of oral epithelium 0.2 to 0.3 mm. Epidermal type differentiation cytokeratin K1, K2, K10, K12. Stratification specific cytokeratin K5 and K14. Cytokeratin in highly proliferative epithelia K6 and K. These are important. Turnover time for palate, tongue and cheek 5 to 6 10. Turnover time for gingiva 10 to 12 days. Turnover time for junctional epithelium 1 to 6 days. Thickness of dental cuticle 0.25. Distance between the apical end of the junctional epithelium and the crest of the alveolus 1.07. Thickness of acellular extrinsic fiber cementum 30 to 230 micrometer. So turnover time for palate, tongue and cheeks. Reminder to the drink water. 5 to 6 10. Turnover time for gingiva 10 to 12 days. Turnover time for junctional epithelium 1 to 6 days. Thickness of dental cuticle 0.25. Distance between the apical end of the junctional epithelium and the crest of the alveolus 1.07 mm. Thickness of acellular extrinsic fiber cementum is 30 to 230 micrometer. Thickness of acellular fibrillar cementum 1 to 15 micrometer. Thickness of cellular mixed stratified cementum 100 to 1000 micrometer. Width of cemento-dental junction 2 to 3 micrometer. Distance between the crest of alveolar bone and CEJ 0.75 to 1.49 mm. Threshold level for surface roughness above which bacterial adhesion will be facilitated, 0.2 micrometer. Inorganic content of calculus, we have seen hydroxyapatite, magnesium white and octo calcium phosphate brucite. Organic component is carbohydrate, proteins and lipids. Average daily increments of calculus is 0.1 to 0.15 of dry weight. Gene mutation causing papillon-Lever syndrome, it's cathepsin C gene located on chromosome 11. Cathepsin C. Resident leukocyte, mast cell, peripheral dendritic cells, and histiocytes. Kinin-like complement C2A, NFI-like toxin C3A and C5A, chemotaxin C5A, opsonine C3B. Regulars of complement activation, factors H, membrane cofactor, protein, complement receptor 1, complement receptor 2, decay accelerating factor, C4 binding protein. How many times in a day lymphocytes recirculate in blood? 50 times. Okay. Antigen presenting cells, peripheral dendritic cells and monocytic derivatives and B cells. Chromosomes on which MHC is located, short arm of chromosome 6. Okay. Mutation of which gene causes X-linked hyperimmunoglobulinemia M syndrome, GP39. Global membrane receptor defect, GP110. Who gave theory of whole cell extraction of teeth? Hunter. Complication of diabetes by Lowy, retinopathy, nephropathy, neuropathy, macrovascular disease, alter wound healing, periodontal disease. Area of dorsal tongue mucosa, 25 centimeters square. Composition of mouth rinse for halitosis, 0.05 chlorhexidine, 0.05 CPC, 0.14 zinc lactate. Mean GCF volume in proximal species for molars, 0.43 to 1.56. GCF per day was 0.5 to 2.4 ml. Glucose concentration in GCF is 3 to 4 times greater than in serum. Coagulation factor present in saliva, factor 8, 9, 10 and PTA Hagman factor. Okay. Course of primary herpestic gingival stomatitis is 7 to 10 days. Puberty gingivitis occurs at the age of 11 to 13 years. Lidex ointment contains 0.05% flucononate. Major antigenic determinant for cicatricial pemphigoid is bullous pemphigoid 1 and 2. Radius of action 1.5 to 2.5 mm. Antigens associated with the. Okay, so we were at coagulation factors, done. Okay. Antigen associated with aggressive periodontitis, HLA-A9 and B15. Human herpes virus 8 is associated with Kaposi's sarcoma. Sensitivity of periotemp probe is 0.1 degrees Celsius. Diameter of probe tip of Florida probe is 0.4 mm. Evalucide detects microbes AA, PG and PI. Perioguard to detect aspirate aminotransferate level in GCF. Periocheck to detect neutral proteases in GCF, MMP2. Gelatinase A, MMP9, gelatinase B, MMP8, collagenase 2, MMP13, collagenase 3, MMP3, stromalysine 1. Diameter of endoscope used in perioscopy system 0.9 mm. Concentration of tetracycline is 2 to 10 times. Atridox contains 10% doxycycline. Arestine contains 2% minocycline. Size of the periochip is 4 into 5 into 0.35 mm. How many days does periochip takes to biodegrade is 7 to 10 days. And chemically modified tetracyclines which lacks antibiotic activity by restricting anti-MMP activity, CMT3 and CMT8. Working time of Coipac is 15 to 20 minutes. During healing after scaling and curettage, immature collagen fibers appears within 21 days. Incision of gingivectomy is beveled at an angle of 45 degree. Wavelength of CO2 lasers 10,600 nanometer. Wavelength of NDYAG layer 1064. Internal bevel incision is given with number 11 and number 15 surgical scalpel, and clavicular incision is given with number 12 blade. Interdental incision is given with Auburn knife. Resorption time of plain gut suture is 30 days. Resorption time of chromic gut suture is 45 to 60 days. Wavelength of diode laser is 655,980 nanometer. Wavelength of ERYAG laser is 2940 nanometer. Biological width 2.04 mm. Bone required around all surface implant is 1 to 1.5 mm. Minimal mesial distal space for an implant placed between two teeth is 7 mm. Bone appositional index for implant in the posterior maxilla 30% to 60%. Bone appositional index for implant in the anterior mandible is 65 to 90%. Miscellaneous ectalasia is a genetic or inherited disorder associated with the early onset of periodontitis due to deficiency of catalase agent. Acatalasia. Electrosurgery and radiosurgery is surgical techniques performed on soft tissue using controlled high-frequency electrical currents in the range of 1.5 to 7.5 million cycles per second or megahertz. The four types of electrical surgeries are electrosection, electrocoagulation, electrofulguration, and electrodesiccation. Electrosection, electrocoagulation, electrofulguration, and electrodesiccation. The three classes of active electrolyte used in electrosurgeries are single wire electrodes, which is for incising and excising, loop electrode for planing tissues, and heavy bulkier electrode for coagulation procedures. Incising and excising with a single wire. For planing, it's loop electrodes, and for coagulation procedure, it's heavy bulkier electrodes. Electrosection or electrotomy or accusection is used in incision, excision, and tissue planning. Electrocoagulation provides the control of hemorrhage by using electrocoagulation current. Electrosection and electro are most commonly used in all areas of dentistry. Electrofulguration and electrodesiccation are not used in dentistry. Only electrosection and electrocoagulation is used in dentistry. Electrofulguration and electrodesiccation are not used in dentistry. The most important basic rule of electrosurgery is always to keep the tip moving. Prolonged or repeated application causes heat accumulation and tissue destruction. Now, type of electrode and uses: needle electrode and removal of gingival enlargement and gingivoplasty to make the incision to establish drainage in treatment of acute periodontal abscess. Needle electrode supplement by the small ovoid loop or diamond-shaped electrodes used for fish tuning. During reshaping, the electrode is activated and moved in a concise shaving motion. Ball electrode, it's hemostasis. Thin bar-shaped electrode, control of bleeding points located interproximally. Electrosurgery is mainly helpful for the control of isolated bleeding points. Loop electrode, relocation of frenum and muscle attachment to facilitate pocket elimination. Removal of flap after the acute symptoms subside. What are the disadvantages of the surgery? Cannot be used in patients who have non-compatible or poorly shielded cardiac pacemakers, caused an unpleasant odor, and if the electrosurgery point touches the bone, irreparable damage can be done. Heat generated by injudicious use can cause tissue damage and loss of periodontal support. When the electrode touches the root areas of the cementum, burns are produced.